So I'm going to introduce Dr. Laura Rosella. She's a tenured professor at the Dalla Lana School of Public Health at the University of Toronto. She holds a Canada Research Chair in Population Health Analytics and the Stephen Family Research Chair in Community Health at the Institute for Better Health. She's the education lead for the T. Karam and Associate Director of Education at the Data Science Institute. She leads the AI for Public Health Research Training Platform, which is focused on establishing a workforce of public health researchers and practitioners who develop and apply innovations in AI to public health research, policy, and practice. Her research covers AI applications to population health and includes predictive modeling and research that supports public health planning and population health management. She's authored over 280 peer-reviewed publications and was named one of Canada's top 40 under 40 and was recently inducted into the Royal Society of Canada's College of New Scholars. Please join me in welcoming her to the stage.
All right, thank you so much for that kind introduction. Just make sure this is working right. Okay, I'm really pleased to be here with you all today. Thank you so much to the organizers for inviting me. In the next 20 minutes or so, I'm going to talk about, we're at the end of the conference, and we're kind of talking about where do we go from here. So I'm going to talk about the AI tipping point. So a tipping point is a point at which, when you're on the other side, everything's different, right? So for us in healthcare, we haven't gotten there yet, right? We're still very much on the pre-side. So I'm going to talk about how we get there, talk about why it hasn't happened yet, and how we get there. And as was mentioned in my bio, I work mostly with population level data, building algorithms and trying to get these into practice. I've been doing that for my entire academic career. But I also really like the space between healthcare and public health and population health. I think that's where we need to make the most progress. So I'm going to bring that into our discussion today. Some of you have computer science background, so I hope to give you sort of the inside scoop a little bit more on what it's like to actually deploy and make a difference in healthcare. If you're coming from a healthcare perspective, trying to give you a bit more appreciation on what we need to do on the methods. And if anyone here is on the legal or ethical point of view, we need solutions. So I'm going to be talking about some of those in a moment. So let's talk about context. If you haven't been listening to the news, our healthcare system is in crisis in most countries actually around the world. We have major capacity challenges, workforce shortages, burnout, increasing costs, you name it. We need a healthcare system to rise to the current challenges of today, and we're not quite there yet. And there is room for machine learning to make a dent on this. This is some of the work I do just to put it in perspective on capacity modeling. So we're in the province of Ontario. We have a single-payer healthcare system. We try to understand what the burden is going to be for our population. And using lots of different modeling techniques, we know that about 10% of the population will need intensive hospitalization at one point in their life, recently. But this is going to go to about 1 in 4. So instead of 1.8 million people needing severe hospitalization, we're going to have about 3.5 million up into 2040. Lots of reasons: aging population, changing demographics, but our capacity challenges are only getting greater. The other context I want to highlight is we've had a lot of change in our health systems, and that's why we're feeling a bit of this friction right now. The first change is, and those of you that work in health systems know that we kind of follow our evidence-based medicine paradigm. We guide what we do with patients and in the health system by high-quality, rigorous scientific evidence. And that usually comes in the form of randomized controlled trial or very rigorously conducted observational studies. And it's changing a bit, but there was a period where we didn't do that. The other piece is, again, some of you that work in healthcare know, it's probably among the most complex environments in the world. From just the human interaction perspective, the complexity, the mix with technology, the strained resources. So even if you have a beautifully performing machine learning technology that can do good, you plop it into a very complex system, it's hard to get it to work. And then finally, we obviously have a brand new data environment in healthcare we didn't have even 10 years ago, definitely not 20 years ago. There's still a lot of paper floating around in our health system, actually, but it's getting better. This is obviously good for advancing machine learning technology, but it's not enough. We're still missing a lot of data points, and the quality is questionable. It's not real-time enough. I'll talk about that in a moment. The other context I just want to bring up is that most health systems are trying to embrace a learning health system. So if you have not heard that term, it came out in about the mid-2000s. It was this shift from a system that was very sort of sequential and one that's constantly learning. Data's coming in, it's being used, there's quality improvement. Evidence is more based on real-world evidence, meaning evidence that's happening in real time, and it's a bit more proactive versus reactive. Really nice idea, makes tons of sense, but in practice, very few health systems function this way. We're just not quite set up. A lot of health systems are trying, including the health system I work with, one of the biggest hospitals in Canada, but it's very difficult, and mostly because of some of the challenges I'll talk about in a few minutes. So why haven't we reached that tipping point yet? Why aren't we at the other side? So lots of reasons. I'm sure we're going to talk about many of them in our discussion. But I'm going to focus on where we need to go with data and methods. And this is, I'm talking a lot to, well, all of you, but the people that actually work on advancing these machine learning methods, and where we need to go on the evidence side. So the first thing I'm going to mention is broadening our data assets. I'm going to touch on our real-time data capture capability and transparency and algorithmic bias. So I'm a population health researcher, right? So I believe that population health is the cornerstone of health systems. So, but also health systems contribute to population health. Again, not health systems were typically set up, which is why we have some of the struggles we have. What do I mean by population health being the cornerstone? It means what happens to people before they get to the hospital matters. It actually matters a lot, and also matters when they leave the hospital. And in fact, the healthcare system is what feels those issues that happen on the population health side first and hardest. When we have major economic downturn, what's the first system in our society that feels it? It's hospitals. And so if we're not paying attention to these factors and working them into our algorithms, it's really hard to make progress. It can feel actually really frustrating. So my question is always, how are we capturing all the determinants of health in our algorithms? Where are we capturing them in our data systems? And these are data I work with quite a bit when I do population health modeling. But I'll have to tell you that the granularity and the quality of this data is quite poor, especially across health systems. Things like socioeconomic status, place. I mean, we've all heard the saying, maybe not, that your postal code predicts your health outcomes more than your genetic code. It doesn't mean we don't look at your genetics, but how can we ignore something as influential to your health outcomes, your access to healthcare, as where you live and what's around you? And it's very inconsistently captured in our health systems right now. So that's where one of the reasons we haven't made as much of an impact. We're talking a lot about multimodal data, which is very exciting. And of course, there's always a little nod to some kind of social determinants or environmental data here, but we are not at the same level of granularity. We're talking about real-time, detailed clinical data with exquisite granularity and capture, and then we have trouble understanding if someone lives alone, for example. And that's really critical when we discharge a patient, or knowing before they got there how that affects their trajectory. So that's where I would say on the data side, we need to push a little further. Every single one of us, I suspect, in this room has had their frustrations with data infrastructure, so I won't say too much about it other than to say we need to start taking seriously the infrastructure for data. It's a life-saving technology. So most health systems, we have bits and pieces that function well in terms of high-quality data that's processed in real time and usable and populating these algorithms. But a lot of health systems, it's not a core function. And if these algorithms are advancing and do have the benefits, which I believe they do, we need to be seeing it as life-saving and just as important as many other aspects of the hospital, and figure out a way to get it funded, sustainable, and maintained. On the algorithmic bias and transparency piece, so I know there's a lot of really cool research I'm seeing in the space at this conference. A lot of people are talking about it. One thing I just want to address that's kind of holding us back, why aren't we there yet, is we hear about the black box all the time. And I think we're actually missing the point a bit. What it's really about, and there's this nice cartoon that was just published trying to explain the difference between what we did when we used traditional statistical methods and how hand-picking variables and really feeling like we're understanding them, and then what happens when you go and you can't do that. Well, it's not necessarily a bad thing if we are focusing on transparency, explainability, and interpretability, and shifting the focus away from just saying, well, if I can't see the variables, I don't understand it. I've taught statistics for 20 years, and I can tell you that lots of people misinterpret generalized linear models in their most simplest form. You can have black boxes in even very simple models. But what we need to be focusing on is making sure that we're adhering to these best practices of explainability and transparency and interpretability. And I'm very happy actually to say that in the last few years, I find the quality of the literature getting a lot better with respect to these aspects. So that's positive. Last thing on algorithmic bias, again, very big topic. We have a lot of excellent research demonstrating the harms that can come from algorithmic bias. And I think why we're not there yet is because we're still seeing these as a problem in our system, and they are. But where we need to be focusing is realizing that that bias, actually a ton of that bias has to do with the data. It goes back to my point about investing in infrastructure. What we measure, how we measure it, the quality of it, it's just not good enough. And if we solve that problem, then we have our aspects of model development or best practices around fairness and subgroup assessment that we can bring in, which I think, again, have increased and have gotten a lot better over the years. But even if all that is working, and it's a fair model, we know it works well across subgroups, we can still have bias in the way that the model is actually deployed in the system. So thinking about all these complexities is kind of going to take us to the next stage. So I now want to talk about evidence, because I think this is where we actually have a further way to go and why we're not quite there yet in the tipping point for machine learning for healthcare. So first of all, solving relevant problems. We hear this a lot at this conference, making sure we're actually doing this. I was thinking of making this as a sticker, but really any problem we should be working on in machine learning in healthcare, you should be able to fill these boxes out. So as a health system decision maker or healthcare provider, if I knew whatever that comes from this machine learning technology, I would do this and it would prove that measurable outcome. And if you can't say that, then we really have to question if this is the right time to work on that problem. It doesn't mean we can never work on this problem, but we actually have to work on problems where there's a measurable outcome, health outcome, that we can say that benefit that, or a health system outcome or a physician outcome that we can actually say is improving. And when I talk as an epidemiologist, I use this story a lot about the importance of evidence. And many of you were born way after any of this happened, so I'll briefly tell you that we supplement folic acid in almost everything we do. It's an evidence-based intervention for women that are pregnant to prevent neural tube defects. But how did we get here, right? So it resulted in both a clinical intervention and a population health intervention. And in the early days, there were just some observations from clinicians, and then it moved to more rigorous testing in observational studies and eventually to randomized controlled trials, where the benefits were so striking they had to stop the trial early. And then we went to, think about it, fortifying food, that's how important it is. And then providing evidence-based recommendations. So why am I telling you this story? I'm telling you this story because for machine learning and healthcare, our evidence base for driving this kind of change is still in the very early days. We really need to be showing in rigorous, high-quality studies that outcomes are improving. And it's starting to happen. We're definitely seeing more deployments and more prospective studies. We're seeing randomized studies of algorithms. It's definitely starting. But until we have a critical mass, we're not going to see that change. And there's a couple, there's a story with HPV as well. I'll skip that, but let's talk about robotic surgery as another example of evidence, which obviously is mostly very heavily driven by machine learning now, not as much in the beginning, but very much so now. And the cool thing about robotic surgery, and probably some of you work in this space, is that from the beginning, the reason why we were testing it was to improve surgical processes and patient outcomes. It was never about the technology at the beginning. It was always about how do we make surgery safer and how to improve the quality of surgery. And so the technology evolved alongside the evidence, high quality evidence of impact, and where we are today is actually in a pretty good place for robotic surgery. So more akin to what we want to see in other applications. Okay, so we know what our roadblocks have been a bit. I'm going to tell you a couple more. How do we get there? And so for this final section, I just want to emphasize a few of the things that are outside the algorithm parts and talk about things like regulation, change management, and infrastructure. And these are things that are the responsibility of some individuals for sure, especially some of our model building practices, but really it's about organizations and society. So on the regulatory side, a lot of people don't like that term. They think that's stifling innovation. But actually, we need regulation, especially for some of the areas that we know are high risk. And we know at this point in time, we're not ready to take on. But it's not enough. These should be just very high level, very specific applications. We want to leave room for that innovation. So it's kind of like the Swiss cheese model of creating the environment for responsible healthcare. Guidelines are the other piece, which we're starting to see now from the AMA, from the FDA, from lots of physician organizations and machine learning organizations, as well as standards for best practices. And so again, we're now kind of defining as a group what the rules of engagement are, what's in, what's acceptable, what's not acceptable. We need that, or else what happens is we deem everything unacceptable because we're still worried about these high-risk situations. The flip side to that is engagement. Engagement with patients, practitioners, operators, right from what problems we're solving to begin with, to deployment, to design, to evaluation. And if we don't do that, we will not build trust. And we all see what happens when you don't have trust in science, right? And it has to start from the beginning. These need to be based on authentic relationships. They cannot be rushed. And so it's something that this is work I'm involved in, we should all be involved in, and alongside the regulation will create that environment where some of our advances can thrive. Some of the other work I've been doing is thinking with organizations how they ready themselves for data science or machine learning capabilities. What we've noticed across organizations, this is with public sector health organizations, which are really behind, but hospitals are pretty close, is that you might see some movement in a particular area, but not in all the domains. And really, it needs to be a stated organizational priority right from the top. There needs to be strong leadership, dedicated funding, change management, education. It's on purpose. You're saying, we're doing this. And you're doing it across the organization, and you're setting up the organization to be able to do that. Otherwise, it will just be a couple of projects that might be successful and show impact, but it won't change healthcare. We won't get to that tipping point. And last, if you recognize those two guys, you'll know my two favorite TV shows. But what can we learn from some extreme examples, right? It's helpful to think through the extremes to think, how do we keep this safe and regulated so we can actually make the progress we need? So controlled growth is one of them. So it can feel frustrating. I know for myself it's felt frustrating, feels like we're going so slow, almost backwards, but some of that controlled growth is actually important to help mitigate some of the risks. Intentional redundancy is one I think a lot about. I don't think we're intentionally being redundant in the machine learning technologies we're building. Who's at the table, who's not at the table. We need more diversity in the types of solutions that are in there. And, we might just have to call certain applications off for now, which we are seeing in some jurisdictions, not necessarily in healthcare, but in Europe, for example, banning facial recognition applications, autonomous weapons. Like there's some fairly obvious ones that we should just take off the table for the time being so that, again, we can focus on the spaces where we feel like we can do good with this technology. And this is a team sport, right? So I'm involved in a project where we're deploying diabetes prediction models for both prediction of the onset of diabetes and complications. And I co-lead that project with a bioethicist who thinks about the deployment of AI and digital technology. I didn't think that was going to happen 20 years ago when I started my career, but now I understand how important that is having that co-perspective on everything that we're doing. We have an implementation lead, we have a human-centered design lead, we have regulation expertise, and obviously we have clinical expertise. These are the types of teams that are going to enable the success and impact in healthcare. Last couple things I'll mention are just, anyone that knows me knows I'm really passionate about education in AI in healthcare and in public health. And the reason why is because I think of all the things I'll do, actually in my career, this is probably the most important because we're changing the way a workforce, a generation is actually interacting with this technology in a responsible way. So I'm the education lead for TCARM, amazing organization in Toronto, Center for AI Research, Education and Medicine, so look them up if you haven't. But we think a lot about the different audiences that we want to build capacity in. It's not one, not everybody needs, one Python 101 or whatever course that we're giving all different trainees. Actually, depending on the frame you're coming from, you might need different training. And we were the first medical school in Canada to make AI mandatory. So every medical student that goes through our medical school has AI in their first and second year. And I'm starting to see, after doing this role for now 4 years, the change. There's a complete change in the phenotype of people going into healthcare, their acceptability, the questions they're asking, both critical questions and also being very excited about the technology. So we're starting to see that change, and it starts with education. And I also lead a platform nationally doing the same thing for public health practitioners, which again, after 3 years, starting to see the change, the acceptance, and the capability of these systems to actually do that. So this is my second last slide. How will we know whether or not we've reached a tipping point? And so I have things here like fewer people developing preventable diseases, improved patient outcomes, more efficient delivery of care, improved experience of healthcare providers. There's nothing about machine learning or technology in there, right? Our North Star has to be, we're changing our health system. These are the elements of a high-functioning healthcare system and a public health system. And until we can demonstrate with high-quality scientific evidence that the machine learning technologies are actually resulting in these things, it's going to be hard to drive change. But I believe they can contribute to them, which is why I'm in this space. So after the tipping point, what's it going to look like? So this is what I have in my head when I'm working in this space, that we're going to have these broad data sources, and we're going to really enhance our population health data sources. Again, I think this is the evolution of the current health system we have and the health system we need to deal with those massive capacity curves I showed you. We need to be thinking about people and all aspects of people. And so we'll have this multimodal data that's scaled, it's widely adopted, and it's being used to address major health issues, in particular improving health outcomes and balancing our capacity. And that mature governance and monitoring and transparent background that I was talking about is going to be there. That's actually what's going to enable us to do the work and do the innovation, which is why it's so important for us not to see it necessarily as a barrier, but something that we create and we make sure it's well functioning. So that is it for me, and I look forward to discussions later. Thank you.